Good morning.
Good morning.
It's an honor to have an interview with you. And
My pleasure.
I would like to start with the first question because, I graduated 10 years after you. And as I started to travel, to join meetings, I saw you many, many times from the beginning of my career. And that's why I'd like to ask you, how did it happen that you are so much involved in teaching and lecturing in your professional life? Because I know that it takes a lot of big place in the life, because not every dentist does this.
No, not every dentist does it. Well, it started it was about 87. And I was still at the university. I was at the department of Professor Peter Scherer, famous dentist. But one of my mentors was Professor Jörg Stroop. And we had, I would say we had a very lucky time because we were involved with implant dentistry at the time. And we started to try to make things look good. Because at this time, everybody was happy to have an implant that was stable in the bone and something on top of it, and it really did not look like a crown. But we, coming from the prosthetic department, where I'm specialized as well, so we thought, well, maybe we can make it a little bit nicer. So we had a chance really to start something nobody did around the world at the time. And we, for example, did the very first porcelain fused to metal bridge on a dentalist arch, fixed bridge. And my first lecture, and that's actually is the answer for your question, was I could go together with Professor Stroop, who was involved in lecturing, and show this bridge, because I did it together with him, in Chicago. I never forget that. So that was actually my first lecture was not in Switzerland. My first lecture was already in the States. And then we did other things. We did special abutments already in 1986 too. So that's how it started. We tried things. We did things nobody did before because we were at the right spot at the right time. And as you know, once you show something, they might be interested to see what else you do, and then they start to inviting. And ask you again. I never planned to do it, and that's where I'm now.
Okay.
Today.
So it just happened.
It just happened.
Okay. That's okay. You said that you've been working in university in the prosthetic department.
Yes.
And I know that very shortly after graduation you made your doctor's degree.
Yes.
But your theses were not prosthetic. They
No.
were surgical. Right?
Well, yes.
So, from one hand, you've been working in the prosthetic department, but your doctor's thesis were surgical. And I know, because we've been talking before, that you do both.
Yes.
Prosthetic and surgery.
Yeah.
So my question is why? Because I'm not that widely educated. I'm a prosthodontist, but I don't do surgery at all.
Yeah.
I have a very good surgeon, okay.
I know.
Yes. But why did it happen? Is that was because, the surgeons you've been working with before didn't do it the right way? You wanted to do it yourself?
No, not at all. I said I was at the department of Professor Peter Scherer. He was at the department of prosto, but he himself was also trained as a periodontist. And that was the time when we actually discussed that periopros would be the right thing. Maybe you remember, no you can't remember, you're younger, but in the States, periopros these were the famous programs. They were always periopros.
They still have it.
They still have it, but it's not as famous anymore, unfortunately, because the big leaders are not there. That's another story. We don't have the big leaders today anymore. However, this periopros program was also kind of the program I actually did in Zurich. So we already did, when we did the prosto part, we did the perio by ourselves first. At the time, it was called pre-treatment, which is for a periodontist a terrible thing to say, as you might know. And this is one part of the story. The other part of the story is actually at the University of Zurich. They did some dental implants already, but the old style, they had terrible failures. So it was forbidden to place implants anymore. My other mentor, I already mentioned, Professor Stroop, he actually restarted to placing implants at the department, and that's how I got involved. So in our department at the time, 85, 86, 87, we were the only department at the University of Zurich that started to place implant, that was involved in implant industry, and that's how I got in this field.
And now you do both.
Now I do both. I love to do both. I love to control the surgical procedure and then not have somebody else to make the crown, because I like to make my own nice crowns. Soft tissue management, prosthetic part, that's a very important thing.
And there's no one to blame if there's something wrong, right?
I can blame myself.
Yeah, exactly. So you have to avoid that. Okay.
I did.
Okay, so getting back to your graduation was 1982, and it was exactly the same year, as I remember, as Brandenburg introduced his first commercial available implant system in Toronto.
Yeah.
So we can say somehow that your professional career started exactly in the moment when implants started to be...
Let's say the modern generation of implants. We should not forget. I placed an Lincoln blade in my life.
Oh, really?
I did.
Oh, you're the first person I know now who did that.
To tell you the whole story, I placed this implant. I modified already the head because we want to have something else, and I placed it, but I never restored it because my patient died, not because of the implant. There was other reasons.
I believe that. Okay. What year was it?
That was in 80, must have been 84, something like that.
Mm-hmm. But you never did it after? It was...
No. I removed them later on.
Okay.
But there are still some patients I see, they have a link of blades and they're still functioning.
People who still place them.
Oh,
yes.
Okay, well, that's another story.
In a very, very, very narrow.
Very narrow.
Range.
Yeah.
But it's unpredictable.
Right.
Okay, so anyway, from 1982 till today, you are like parallel to the development of modern implants, right? So
yeah.
you are involved in it.
Right.
That's fine. Now, as I prepared myself to this interview, you know, I just went to Medline to see your publications, and getting back to the thing I started, that you're a prosthodontist, I mean, from the specialization point of view. But as I look at the publication you did, I think they're mainly involved with surgery.
Right.
Right?
Right.
Why is it so?
Well, it's more interesting for me. You know, I think the surgical part is more dependent on really how we do the details. The technical part is more dependent on the lab. We have to tell the lab exactly, on implants especially, you know, on implants. So with natural teeth, of course, that's a different story. But I published mainly on implants or only on implants, and the technical part is really the dental technician who has to understand what to do if I did the surgical procedure correct.
Okay. And you know, looking back from 1982 when we started with implant dentistry, what do you think is the biggest change? Because 1982 Brandenburg system was more or less the same as we do today. Screw, which we put in bone, okay, some kind of connection with some screw, some abutment, right? But what do you think is the most important, you know, development, you know, evolution in implants?
Well, after
so many years.
After the Brandenburg, there are, I would say, 2 or 3 things. One for sure is that the prosthetic components changed, which actually is a big work was done by Rich Losara. I don't know whether you know this story. You know that because he is a practitioner who thought, well, with the standard abutment we had at the time, there were only parallel abutments, and they were high water abutments, so terrible. So he started to produce special abutments. They fitted on the Brandenburg implants. Later on, he said, well, I can do the implants as well. There was a big change, and that was very important for me. Just to tell you, I just was invited to Rich's 70th birthday in Italy, and I went there because we had a very good time together, a lot of discussion. This is one thing.
70.
Yes. The second thing is, but this is not, well, of course, this is how we make bone, you know, the whole thing. In the old days, they would really place the implants where there was bone.
Right.
And the change to place the implant prosthetically correct and to create the bone, the whole GBR, there was a big change at the early 90s, late 80s, early 90s. There was a very big change. And a lot of people think the big change is that we add the soft tissue management. But if I look back, actually, the GBR we started in 1990, 1991. The soft tissue we started already there. We did already soft tissue grafting there. So
you can separate them.
yes,
Right.
but this is what we do today. And then there are other changes that are not good. We all have rough surface today. We think that's a big advantage, and actually this advantage, as we all know, might be a disadvantage. There is a lot of pressure from the company that we think our patients, they want to have it done in one day. But if we really explain our patient that maybe if we have a little bit more time, we can do something that is more predictable in the long term. So there are other changes that are not as good as we think they are.
I think there was a fashion in implant dentistry to make very, very much cases, a lot of cases. I was immediate implantation, immediate.
Oh, I published, maybe you have seen.
Yeah.
I should do the same publication today. It will look totally different, you know.
That's what I wanted to hear.
I tell you a story. Well, this was actually in 1997. I was waiting for a patient because sometimes I had something in my mind. I want to do this, and the patient is not here. So I was waiting for my ideal patient. One day he came in. This was 1997. At the time, nobody did it, so I did. I extracted all the teeth. There were really perio-involved teeth, no chance to solve them. I extracted all the upper teeth and placed the implants. I extracted all the lower teeth, placed the implants in the morning, made the impression, and in the evening this patient left the office with fixed temporary on upper and lower. So this was not only immediate loading, this was the first thing we ever did, immediate extraction, immediate loading, upper and lower.
1997.
1997. And then I published, I did several of these cases. I published a study, I don't know what it was, with a very good outcome. I think it was after 2 years. Some have a very good outcomes, some not. I learned a lot from these studies. If you have big bone defect and place the implants and don't know what to do with the defect, well, it's easy, the defect stays. And then you have problems.
Maybe you should, 2017, 20 years later, you should rewrite this
yes.
paper.
Now, the actual situation of this story, the man who came in 1997, I haven't seen him. Because he had got everything in one day. Later on, well, he got the temporary. Later on, we finalized with fixed porcelain reconstruction. However, he thought, well, it was so easy and everything works. And he was busy, man. He never came back. And I thought, well, I have to find this man. And just a week ago, our staff, he found his name again. We called him, and he came 19 years later.
And?
Yes. And I tell you the truth. He never cleaned in between. He never did. It was all swollen, but everything is still there. The bone resorption goes down to the first thread as with all this implant. Well, on the bone level, it's great. And now we're bringing back in a program, but the porcelain is all rotten down. Fracture here, fracture there, because it's porcelain against porcelain, as we know. And
used to metal, right?
Yeah, and it was a very positive. For me, even if he never cleaned, the soft tissue swollen whatsoever, we have mucositis everywhere, but a very positive outcome regarding bone level. But this was the right case to do it. And I was waiting for him because he had no angular bony defects. The bone was, parallel down. And if it's parallel down, I still would do it today. If I have these bony craters before extractees, I would not do it. So we learned a lot by mistakes.
Okay. So wait now for the second part of this article from 1997.
Yeah, that would be interesting.
But when we talk about writing, here we have this fantastic book, which just showed up, 2016, right?
The German one, 2015, and the English, now it's English.
So it's implantation in aesthetic, implants in aesthetic zone. Yeah. It's a huge book, huge work. It's over 850 pages. So what can you tell us about it? Who is this book for? For the beginners or for advanced? What is it about?
Let's say it in a different way. It's for me.
Okay.
It's I'm very happy if people are reading it, but this is what I did the last 20-25 years. So I document every case I did from the aesthetic zone, every case. And if you look at the book, the documentation is very much standardized, always the same pictures, three-dimensional occlusion and so on. And a lot of people ask me, always write a book like this. And I did it, and I think it is, I don't know whether it's for the beginner, it's not.
It's not.
No.
Okay.
It's not for the beginner because the beginner, they have to learn how to make an incision, how to use a needle, how to do things like this. It's for somebody who really already placed some implants Maybe he's not advanced, but he knows the basics. And then there are a lot. The interesting thing about this book, I think, is there are more than 400 different cases. 4,000 pictures, but more than 400 cases. Okay. So it's not just one case, what sometimes you see in the book, one case over 200 pages. But here I really looked at details, and this was the big work to do. So, well, where did I make my incision wrong, half a millimeter wrong? And then I find the case, and then it's an example of doing the incision in a wrong position, or make a suture wrong, or all this. This is what it's all about. It's about a lot of details, a lot of possible little things you can change in order to be successful. And then it takes a lot of time to go through it.
It's the saying, the devil stays in details.
Mm-hmm. Right.
Okay.
Absolutely.
But when you talk about books, I don't know if you've already seen that, because it was also published this year. It's a huge book published by Wiley, actually, which is titled Complications in Implant Dentistry.
I haven't seen, but sounds interesting.
Yes, it's also about 800 pages.
Yeah.
About 30 chapters. And you see this probably the same, because when I travel now and take part of meetings, there are more and more lectures about failures, about long-term failures, and even there's this saying which showed up: the more we learn about implants, the more we save teeth. So how would you comment this statement after so many years of experience in implant dentistry?
The failures.
And the failures, the long-term failures, the behavior of implants with a year, because they behave different than teeth, we know that, right? Mm-hmm. So a few words about this, your own observations. There's a lot of talk about, craniofacial growth factor, that implants behave different than teeth, yes. That there are some changes in the occlusal plane, etc., etc.
Well, that's interesting, because, that the teeth are moving, we knew, but now we see it. Yeah. If you have one implant and all the other teeth are moving, I see this all the time. The people come back and everything changed over the years. But, talk about failures is nice, but we have to talk about how we can avoid making failures, and that's more important, actually. And we learned it already years ago that, for example, if you have a single tooth, you always have, in the aesthetic area, we have to make a retention. So we started to make retentions, and nobody does. And we see we have to do it, because we have to stabilize the teeth, because the implants are stable. We think, we don't know. It was just a publication by Daftari and Bahat, yes. As you know.
Yes.
And I had a lot of discussion. We were also planning to make a publication on such cases. And it's interesting, if you go into detail, we don't know, is there only eruption of the teeth? Is there still growing of bone? We don't know. Orthodontists don't know. And I can show you cases where we have incredible movement of teeth, no problem, the implant stays there. But I can show you, for example, two implants placed close to each other with a nice contact. Over the years, I have a diastema between two implants. Have you seen this? I can show you. I can show you almost everything.
I can't believe that.
So what happens? And I think it's a combination of both, but we don't know. And failures are very important, but failures are only important if we analyze them and we learn to avoid having these failures. And nowadays, with this peri-implantitis, we see peri-implantitis. And there are a lot of studies that show, well, where the surface is not so important, and other studies show that it might be important. And if I look at our cases where we always had machine surfaces at the beginning, of course, we see more peri-implantitis without doing any studies with the rough surface. And that's it. That's why I said sometimes it goes in the wrong direction.
As you said, we don't know why it happens here or there, right? Because there is also the less predictable part of our treatment,
right,
which is patience.
But I learned something. That was Hannes Wachtel. We were talking about him. It does this all-on-4 stuff. I don't like it whatsoever. And then I said, well, what would you do if you have a failure? He said something very interesting to me. Why do we think implants should last forever? If you have a hip prosthesis, they replace them after 10 years. And that's it. Nobody's complaining. And we think our implants, well, I think they should last forever, but maybe why should our implants last forever? Why are they allowed to replace the hip prosthesis all the time, and that's normal, and we think if we have a peri-implantitis problem, it's an interesting aspect, right?
I think it's a question of marketing of the companies, because they have all this, commercial statement, implants for life.
Yeah.
And patients believe this.
Yeah. And now we know it might not be. In some cases, yes.
That's what I say. My patients, remember, this is only prosthesis. It will never be as good as your tooth.
Yeah,
It's
right.
impossible.
That's why we still fight for every tooth. Right. And sometimes it's interesting that our patients, they come and they don't want their teeth. Right now I have a lady, she wants to have, she gets implants on both sides, and they have 3 natural teeth, we can keep them. She wants to have them extracted. I have a big fight with my patient. I don't want to extract them. So it can happen.
Because they believe in commercials.
Right. Yeah.
Okay. Now, getting back to your life, you've been involved in your life in many activities, in many organizations, implant and dental, whatever, and also I know that you've been a president of European Academy of Aesthetic Dentistry, and I think you are involved in activity of European Academy of Aesthetic Dentistry from its beginning. I believe so.
No, not from its beginning.
It was like 1986 or something?
Yeah, but I came in later.
You came later?
Yeah.
What can you tell us about this part of your activity?
Well, the big activity actually I did in the Swiss Society of Implantology. There I was a member of the board for 21 years.
Oh,
so there was a very small group, and when I left there was a real academy, and so it was a lot of work. And in the European Academy also I'm still involved. For many years I was involved. For example, I was a member of the board. There were so many people in the board, and the European Academy of Aesthetic Dentistry, the people are not easy. Those are all big egos. Yes. So I remember when I was a member of the board, it was something in the 90s, I decided that we have to reduce the number of people in the board. So I reduced myself, I went out, and I came in later on. So, it's a very interesting part, because I'm interested actually to see how people can work together, especially how we can discuss things together, how we can improve things. Yeah, I like to see good meetings. We have our own small meeting in Switzerland also. We have a so-called Snowden. We do our meeting. I like to organize it. I like to have put lectures on the right spot and then have good discussion. I like discussions.
Yeah, that makes sense, of course, because discussions is where we learn most.
Yeah.
Okay, so now we've been talking about dental life, your dental career, but everybody gets some kind of hobby which keeps you away when you need it from your activities, everyday activities.
No.
You don't have it?
I have had it. And I still have it somewhere.
So that's what I want to ask you. Do you still have time for something else?
No. Tell you the truth. I love sports, and I was a pretty good sailor. I was a European champion and everything, so I sailed a lot, the competition.
You want a category? What category?
I was European champion was 5.5. You might not know that. It was until I don't know which age was Olympic. And so I always have had a sailing boat. I still have a sailing boat, a very nice yacht for 3 people. If I go all alone. This year I went once. Last year I went twice on my boat. The year before I went once. So this
unbelievable, because I have also a 3-people boat.
And you never go.
And I was twice this year.
Yeah, you're better. 50% better. 100% better.
One with my wife.
And whenever I go, it's great. So maybe, if I'm allowed to say, we're both a little bit stupid.
Yeah, we're dentists.
Yeah. No, we are fascinated about what we're doing. That's why. Yes. I said, I'm a really lucky man. My hobby and my job, they're similar. I really like to do with them.
I think it's okay, because if you do something with passion, you do something good.
Yeah.
If you do it only just to make living, it's not enough.
Another story. I was lecturing in Japan, flying back home and sitting all alone in my airplane. We overflew Africa. I watched down, and there is the desert, and I think it's incredible, There are people out there, they have no water, they have maybe nothing to eat. And I'm traveling all the way to Japan to talk about how we can gain 2 millimeters of soft
enjoy it.
tissue. How stupid is that?
Now
Half an hour later, the story is not finished. Half an hour later, I said to myself, isn't that incredible? Nobody needs what I'm really doing. I love to do it, and people pay for it. How lucky I am.
Now we're turning a bit into philosophy.
Yeah.
Philosophical.
But this is, yeah.
I know that you will be lecturing next year in Poland.
Yeah.
There will be a whole session. It's written here. It will be in November.
Yeah.
And you will stay here for longer. Can you tell us anything about it?
Yes.
What will it be? Who it will be addressed to?
Well, it will be, everybody should have a concept how you treat patients. So I can go through the whole concept, and that's nice. Actually, it's not just you doing the surgical part or how you cut. Because this is very important, of course. But the concept means you have to understand, you have to analyze the patient, which is, for example, is a very important thing. Find out where are the difficulties, where are the limitations before you start treatment and all this. And then you find out what to do when you extract the tooth and discuss this. So a whole concept from the start to the end, including prosthetic, because that's what I do too. And that's, I think, if somebody is willing really to sit long enough, that's the interesting thing. It's a whole story, not just some details here and there.
Prosthetic and surgical.
And surgical.
And periodontal.
Yes, everything.
And
everything.
Will it be like the book for more advanced people, or also for the beginners? It will be like a basic also?
It is less basic, I would say.
More
I never lectured basic.
Basics.
I never did. And that's not because I'm snobbish, I hope not, but I never documented basic. We did at the very, very, very beginning, at the 80s, how to place an implant, how to drill. Of course, I can show how we place an implant. That is included too, because I have some videos and you can see this. But I think to know how to place an implant, this is helpful if you come to the course, if you already did. But if you never placed an implant, it might not be very interesting. Well, might be, I don't know. And sometimes I have orthodontists, they come to listen to a course, they never will. But I said, well, that was so interesting for us to know what the possibilities are. I have dental technicians, they come and they are more than fascinated about the surgical part. I said, well, now we know how much work is behind what we finally have to finalize,
We see on the model.
Yes, so I would not say it's not interesting for somebody who's not involved. It can be very interesting, but the whole concept is for somebody who already is a little bit involved in implant dentistry.
Okay, and there's a Professor Husseler and Otto Zu
Yes.
behind me, and he was also lecturing in Poland. He was like a whole day session.
Yeah.
And I know that you've been teaching him, right?
Yes.
Many years ago. He was
Many
a
years
pupil,
ago,
a
yeah.
pupil, right?
Yeah.
Will your lecturing, your session, be somehow connected with what he did?
No,
for
not
us?
at all.
Not at
We have
all?
a total different way to go.
Tell us.
Yes.
Okay.
The group from Munich, and they're great dentists. They always want to have something new, which is good. But sometimes it's really experimental. And they are fair enough, and they come back 1 year and they say, well, it didn't work.
Okay.
But during this year, maybe some dentists tried also, and they also found out it's not working. Now, I have a concept that I know that works for a year. It might be sometimes a little bit not very aggressive, but I know this is how it works in my hand, and it can work in somebody else's hand too. So it's not fancy. Let's say, for example, if I make suture with 3 different type of sutures, I'm done. I don't need any fancy suture. I look at the tissue and I know I have to close it nicely, and then I do my suture very nicely, but nothing with whatever. So it's different, and I think I like to listen to these 2 guys, but my concept is something that works for years, and it's based on long-term experience.
Steady.
Yes.
Okay.
I'm just invited to give a 2-day course in France in 2 years. I will be there. They invited me already 5 years ago. They said, do you give us a 2-day course? I said, I'm happy to come, but I didn't change my concept. And then they said, that's why we want you back.
Okay,
So
that makes sense.
Yeah,
That makes sense.
So it will be a difference.
Okay. So the last question. Okay, I hope that some young attendees of implant dentistry will listen to this interview. So for these beginners, okay, what would be your main message as let's say opinion leader in implant dentistry for those who are beginning?
Yeah.
Yeah, I know it's a tough question because
It's a tough question. It's especially tough because
like in the lecture they say take home message.
okay.
Last week.
Before I can give a take-home message, it's a tough question because I think the young people, they are not as good educated as we were. I'm not happy with what happens at the universities because they don't teach them on a level, because they don't take the time, they don't take care of the students enough. So at least...
It's only our problem.
No. In Switzerland, the students, they finish school, we said they don't know anything. So that's not only your problem. I think it's all over the world a big problem. So what should they do? It's very, very difficult because, if you go to listen to a lecture, you don't learn. It's show, a lecture. One lecture is most often show. If you go to a course, yes, then you can learn. The advice is don't start with the fancy cases because you will be frustrated. Start with simple cases. Ask your mentor, is this a simple case or is this an advanced or a complex case? This is the most important thing. If you start with simple cases and you feel comfortable, you go one step further. If you start with a complex case and you have a failure, that is really frustrating and you will never get to the point that you're a good dentist or good on this topic. And I would, as a young dentist, if I can give an advice to a young dentist, give your cases before you treat them. Just ask a mentor, what do you think? Is this a case I can treat? Yes or no? And hopefully the mentor is fair enough that you're good enough, you treat them. And that is because...
So don't jump on the deep water.
Yes. Tiny little steps. We were very lucky when we were beginners because nobody knew how to do it. We were allowed to make a lot of mistakes and we made them and we learned. And this is different today. There are people that know how to do it, so the young people are not allowed to make all the mistakes we made in the past.
And the patients are different.
That's it.
Thank you very much, Ulrich.
Thank
It was
you
a great
very much.
pleasure.
Yeah, it was my pleasure. Thank you.